time. So what I want to do is try to keep this moving, and I know standing between you and lunch, which is never a good thing to be standing between. So thought we'd talk a little bit about frontline to get started. So this is a 58-year-old who presented with bloating and change in bowel habits, and went to the physician and was found to have an exam showing fullness and pelvic mass, and the ascites was confirmed with detection of a presence of a fluid wave on exam, as well as confirmation by imaging. She underwent exploratory laparotomy and was found to have stage 3C disease that was optimally debulked with THBSO and omentectomy. No evidence of retroperitoneal adenopathy. Several areas of 5 millimeter residual disease in the area of the porta hepatis, and several other small 1 millimeter areas that were widely diffuse at the base of the mesentery and so forth. Performance status is 0. No significant medical history. So would anyone have done anything differently at this point? Would anyone have done neoadjuvant? Does anyone routinely use neoadjuvant? You do? Routinely? Okay. So how would you treat her now? Would you give her platinum paclitaxel IV or platinum docetaxel IV? IP therapy with or without HIPEC? Or would you give Bev? So how many would do number 1? Okay. Number 2? Number 3? Okay. Number 4? Okay. Anything else? Anybody else would do anything differently? Okay. So what schedule would you use if you were going to do the carboplatin paclitaxel, as the majority of you said you would? Would you use dose dense? Who would use dose dense, number 1? Anybody? No? Okay. Every 3 weeks? Okay. Anything other? Okay. All right. So I thought I'd throw this in there just to sort of get a temperature of how people in Saudi treat patients with frontline ovarian cancer. It sounds very similar to what we do. I think, Eric, you said you would do IP. You had a couple of other supporters for IP, but the majority would do IV carbopaclitaxel, which is probably what I would do. I am intrigued by the new HIPEC data, although it's just one study. It's a very small study. It's only 254 patients, or 245, I think. And so I've got to look at those numbers and see. I actually started making slides on the plane over. But I haven't really dived deeply into the details of the conduct of the study and so forth. And there's never been a study where we can't find something wrong with it. If you've ever been to Journal Club at your institution, right? So we'll see how that works out. I think this is one of those areas where there's no clear right or wrong answer. I do think there's levels of evidence that support everything that everyone said. And I really can't fault anyone for any of the choices you made. I think they're all reasonable. In fact, most of the things on the slide are reasonable and defensible in terms of a standard of care. So we have multiple standards of care for frontline treatment at the current time that are affected by insurance reimbursement. They're affected by regional preference. They're affected by individual preference, even within an institution. I think personally, I would probably not do IP on her, and Eric would. We're in the same institution, just to give you an example. I think that if you look at the IP data from an academic standpoint, it's very impressive. You have 3 phase 3 trials showing significant improvement in PFS and OS. However, the way we use it in the real world of lowering the doses, GOG 252 clearly shows it's no better than every 3 week. And I think that the reality is most people are lowering the doses or doing something to modify the GOG 172 regimen. So unless you're sticking strictly to the GOG 172 regimen, I think you're challenged to say that IP is necessarily better, but I'd be happy to hear any comments. This is where we interact, so anyone that has any comments, please feel free. Okay, everyone wants to eat. What about what? Well, I just said I'd go with IV and Eric would go with IP. Probably 50-50. I don't know. Carolyn trained with Eric at Ohio State. And, yeah. But I think they're losing a little enthusiasm after 252. I know that they were all doing IP. It was 3-1 at one point since 252 came out. I know Amanda's kind of switched back a little bit, and Carolyn's not as gung-ho about it as she once was. So, but I don't think, one or two people's vote is important. It's what's the right answer, and I think the either one is correct from the standpoint of very defensible and literature to support it. But oh yeah, in America we are very patient-centric, and a large part of that is medical legal as well. So I certainly discuss all the options because I don't know what the next phase 3 study is going to show, and with there being evidence out there that there has been benefit in the past, I certainly talk to them about the options. I don't spend hours going over it, but I do say these are all different options. These are, I think, good options. Here's the pros and the cons. I mean, the problem with IP in the United States even has been that the uptake has been low. It's under 15% even at its peak. So even when we had phase 3 trials without GOG 252 data, it never exceeded 15%. It was higher in academic centers, and particularly high in GYN-onc academic centers. It was not high by medical oncologists who treated ovarian in academic centers, and it was not high by GYN oncologists that were in the community. And then even there were some academic centers who didn't think it was all that important. So I was a much bigger believer before 252 came out. I was one of the supporters of it. Still recognize that there may be a role for it, but 252 data to me was eye-opening. I expected that to be at least a trend towards positivity, and it really didn't show any benefit at all. Yes. Go ahead. Yeah, but that was at lower doses. That was real world, and the people that designed. The only thing that I have trouble with is the people that designed the 252 IP arm were the biggest proponents of IP. Joan Walker and those folks were given every opportunity. So it wasn't designed by a group of physicians who were biased against IP, so it would fail. It was actually designed by the people who were the biggest proponents of IP. And it failed, and now they're going back saying, well, it's because we had the dose too low. Well, we should have thought of that. Yes?
Part of us not giving IP because we are serving limited population, and basically we're not comfortable because we have small number we are going to give. But my question is that how is the acceptance by the patient with IP versus the IV and with the logistics? The IV is straightforward.
A bigger what? Yeah, there's certainly, there's a hassle factor that's greater with the IP. There's no question, but we certainly are able to do it as an outpatient. We also, frankly, I don't know if it's a lot worse than weekly, where you have to come in every week in terms of dose dense. If you're used to dealing with the catheters, not as big a problem. If you're a medical oncologist, it is a big problem, because if you have a catheter problem, what are you going to do? It's still a problem as a G1 oncologist. You're in another institution, or you're in the OR, and they call you from infusion saying that the catheter is not working. Patient's frustrated, you're frustrated, so all those things happen. But we don't have, if you get used to doing it, we don't have near the catheter dysfunction that we used to have when we were inexperienced. So I think the logistics, we've been able to work through most of those. It's not, and in terms of patient quality of life. I think even 172 showed it. It's a pretty brutal regimen if you use the doses that were used in 172. However, by 6 months after chemo, the quality of life was completely caught up. So there was very little, even though the neuropathy is significantly higher, either you just get used to it, or our quality of life tools aren't very good, because there is long-term neuropathy that's higher. It's 2 to 3 times higher than what you see with IV. But other than that, everything else seems to completely catch up. So I think it's all about counseling. And then there's always the concept of no pain, no gain is the saying, right? So the patient thinks, I have this terrible cancer, and the more I'm doing and the more I'm suffering, the better I must be doing against the cancer. So I think they kind of buy into this. I'm fighting this cancer really hard. I'm doing the most aggressive thing you could possibly be doing, which is true. And then yet there's others of us who say, well, yeah, but when we look at these survival curves, not all that impressive. So, but you can't deny the other phase 3 trials. To completely put all your weight on 252 is to totally ignore all the other trials. But then again, to put all your weight on the other trials and ignore 252 is probably not wise either. I think you kind of have to think about those things in totality.
From the patient perspective, do you have any data, for patients that decide to switch from IP to IV and vice versa?
Well, it's all retrospective data, but when they went back and looked at they've done some ancillary data projects through the GOG, it appears that if you have at least 3 cycles of IP, you confer most of the benefit. So, one of the questions is even, could you potentially just do 3 cycles of IP and then switch, or 3 or 4 cycles and then switch out of that at that point? Because it's really, you really start having trouble on that 4th, 5th, especially the 5th and 6th cycle for many of these patients. Now, granted, you may have made dose reductions and they'll get through it, but if you're trying to get them through at full dose, they really have trouble at that level. Okay. All right. Let's.
Sorry?
Yes.
Is there any evidence that those days would be better option for her more than every 3 weeks, because his performance was 0 and she had some residual disease? So those days is much better for her more than every 3 weeks?
Well, that's a whole nother discussion, and I'd be happy to hear everyone's thoughts on this. And from my interpretation of literature, if she was in Tokyo, then the answer is absolutely yes. And if she's not of Asian background, then the benefit does not appear to be as great. So we don't know. When we look at the 262 subset, that the about 15% of patients who didn't receive bevacizumab, we still saw a benefit from doing it by dose dense, but that was, you have to be careful with that analysis. It was a post hoc analysis, and a small subset of the patients. Yeah, I think there's still, the question's still open, as to what this all means. Icon 8 was a game changer, though, that said there is no benefit for doing dose dense over every 3 weeks, that you have increased toxicity overall, and no benefit. Certainly more costly, it's more inconvenient for the patient, and Icon 8 said there's no advantage. But now here you are again, you have conflicting phase 3 data. And so again, I don't think there's anything wrong with doing dose dense, and if you're a believer from the breast literature and from other things that the dose dense is the way to go, I don't have a problem with that at all. And I think that this remains somewhat unsettled, and the question is, will we have the opportunity to settle it as the science continues to evolve? I think many people would say it'd be great to do more studies to figure this out. Other people would argue our resources should be spent not worrying about whether there's a 2 or 3% advantage in one of these strategies, but rather let's try to do something that's a little more innovative and more of a game changer, so that the women gain actual higher cure rates than what we're currently able to affect. So I think that it's a good question. Any other thoughts on dose dense? Eric, do you do anything different? You said you would do Q3 week if you did the IV.
I feel at this point, the population to be treated, there's no advantage to dose dense therapy in terms of efficacy. There's certainly higher toxicity.
Yeah.
It's a lot more hassle. So I don't generally use it anymore. But that's,
Yeah, but just to play devil's advocate, I also would do every 3 weeks. But if I were arguing with you, I'd say, well, how are you ignoring the JGOG study? How are you ignoring in your own country 262 that showed exactly the same thing when you have Bev into the equation? But Bev, I'm taking Bev out of that group, and in the group that did not receive Bev, there was an advantage for doing dose dense that was statistically significant, of the same magnitude of what you saw in the Japanese study, which was significant clinically. Yeah, but you have 2 studies that showed the same thing out of a phase 3 data set. Okay. Yeah. Yeah. So there's a good example right there. I was taking your side of it, and it shows. And I think that again, there's nothing wrong with any of them.
I do think the last point you made is important. We have spent so many resources in the last 2 decades trying to argue dose dense versus non-dose dense, IP versus not IP, for what ultimately, in retrospect now, is very minimal benefit.
And that's why we're seeing differences among phase 3 trials, because you get slightly different patient populations. The effect size is small enough that you have big studies, you're going to see it swing one way or the other.
And if anything, we may move out progression-free survival, but we don't change the percent of patients who ultimately recur. Not even slightly, there's not even slight improvement there. So I do think this is, these are interim measures until we can develop better therapies. But I do think the multiple things to consider in primary therapy is a good opportunity to set the stage for the patient that, let's be realistic about your cancer. You almost certainly are going to recur after primary therapy. Let's kind of get everything onto the table so that your preferences, kind of what available trials you may be eligible for, therapies in the future, so that there's nothing that there's so many patients who the first time they recur from ovarian cancer are just crushed from the fact that the cancer's back. And we see a lot of these people who are referred to us. They never have, inkling of a discussion that your cancer has about a 90% chance of coming back. They're crushed by the fact that their cancer's back. And we know this is something that's going to happen to almost all these patients. We need to be judicious about the therapies that we're using to kind of set them up for large number of treatments.
Well said. So I'm going to skip the platinum-resistant case because I'm actually eating into my own time, which is really frustrating. So we're supposed to start the lunch symposium a minute ago. So and that's without any further questions. So do you even want to just skip this case so we stay on time? We can do that. Let's just skip the case. Yeah. Why don't we stay, and we're back caught up on time. And if we have time later in the afternoon, I'll be happy to share this case with you. But I think to respect everyone's time, so we stay within the program that's been well planned, we'll go ahead and do that. So journeying to lunch, what are the logistics? Okay. What time do people come back to listen to the symposium? 12:30? What's that? 12:45. There's a lunch symposium, isn't there? Over lunch? There's a lecture during lunch, right? Out there? Oh, okay. So the lecture's out there, so they don't have to return here. I understand. So go to lunch, and I guess I'll be over there somewhere. See you then. Thank you.